Good morning, everyone. Thank you for joining us. My name is Tom Hertz. I am a specialist here at NCCN for business development. I would like to welcome everyone for joining us today for our 2024 NCCN Global Academy. We are excited to have our panelists here for a productive and insightful discussion. For our first panel, when we can move to the agenda, for our first panel, we will have our discussion on Module 1, Adaptation and Implementation of NCCN Guidelines Outside the U.S., Opportunities and Challenges. We will then have a 15-minute break from 10:15 to 10:30. After we come back, our panelists will proceed with Module 2, the role of health technology assessment and other value considerations. With that said, I'd like to pass it off to our wonderful moderator, Cliff Goodman. Thank you.
Well, thank you very much, Tom. It's a pleasure and an honor to be able to facilitate and take part in this international look at clinical practice guidelines, in particular those of NCCN and how they've been adapted and some of the challenges and barriers and opportunities along the way. And so as Tom just mentioned, our first panel is going to address adaptation and implementation of NCCN guidelines outside of the United States. And we have a panel that represents many diverse regions across the globe. And I think you're going to see that adapting NCCN guidelines faces a variety of opportunities and challenges, as I said. But it's important to learn how to characterize these and to be able to get some idea about looking ahead to how we can even do this better. We're going to have 5 panelists for this module, and we're going to go for about 70 minutes. That will be 10:15 a.m. in the United States Eastern Time, and you can adjust accordingly for that. But first, I'm going to have each of our panelists introduce themselves. And for each panelist, I'm going to ask for their name, title, their affiliation, and just briefly in a sentence or two, their connection to the subject of clinical practice guidelines. And we'll start out with Dr. Alshammari. Dr. Alshammari, please introduce yourself.
Thank you, Dr. Goodman. So my name is Kanaan Alshammari. I'm a consultant medical oncologist. I specialize in GI and sarcoma, and I'm affiliated with the Ministry of National Guard for Health Affairs in Riyadh, Saudi Arabia. And my relationship with NCCN is that I am the director of the main NCCN coordinating center in the region. Thank you for having me.
Thank you, Dr. Alshammari. Dr. Trindade.
Hi, everyone. I'm Karine Trindade. I'm a medical oncologist in Fortaleza, in the northeast of Brazil. And as a medical oncologist, I work in an oncology clinic in a private hospital, but I also work in a public hospital for more than 10 years. I work only with urological cancer nowadays. And I'm a member of the Urological Committee of Brazilian Society of Medical Oncologists. In this committee, we have some activities. One of these is to update our treatment guidelines for urologic tumor cancer every year. I also work with research. I'm the research manager of the research center of my institution, and I'm the current chair of LACOG Genitourinary Group, which is the Latin American Cooperative Oncology Group, which worked this year with the NCCN to provide adaptation of NCCN guideline on prostate cancer.
Thank you very much, Dr. Trindade. Let's go to Dr. Rutkowski. Peter.
So good morning or good afternoon, it depends on the time zone. So my name is Piotr Rutkowski. I'm a professor of surgical oncology and head of department for sarcomas and melanomas in National Research Institute of Oncology in Warsaw, Poland. What is more important, I think, for international collaboration, I'm a member of ESMO-ASCO Global Curriculum Working Group, president of Polish Oncological Society, but the most important in the field of NCCN collaboration is that I'm chair of National Oncological Strategy Working Group in Poland, and we are among all other activities responsible for preparation of the guidelines, therapeutic and diagnostic guidelines, and part of these guidelines are adapted from NCCN as a formal document for Polish healthcare system in oncology. Thank you.
Thank you, Piotr. Is Dr. Tsikai back with us?
Yes, I am. I am back. Sorry about the poor network. Yes,
That's
I'm Dr.
okay.
Nomsa. Thank you. Thank you. I am a clinical oncologist from Harare, Zimbabwe. So we do both medical oncology and radiation oncology. I've been involved since 2017 with the NCCN harmonization of the guidelines, adopting them to the sub-Saharan African region. So we've been working with the American Cancer Society, and we have formed what we call the African Cancer Coalition, and we meet on a regular basis to just adopt the guidelines and update them on a regular basis. Thank you.
Great. Thank you, Dr. Tsikai. Great that you are here with us. And Dr. Huong.
Hi, everyone. My name is Huong Chen, and I'm a professor in medicine, and I'm at Hanoi Medical University. I'm also the vice director of the Vietnam National Cancer Institute, and I'm a coordinator for the NCCN guideline harmonization for the region. And nice to meet and discuss with all of you today. Thank you.
Thank you very much. So good to have you. The first thing we'd like to pose to each of you is to just give us, please, if you can, a high-level brief overview of particular characteristics of cancer care in your country. I know we could spend days discussing this, but considering that we have quite diverse international differences in how big the systems are, how wealthy they are, access issues, and so forth, I wonder if we could do that. And I'd like to start with Dr. Alshammari, if you would, Doctor.
Sure, thank you, Clifford. So if I'm going to talk about the MENA region, it's quite a vast and diverse group. We have countries with probably excellent economies who have access to top-notch and most updated therapies, such as Saudi Arabia, United Arab Emirates, and we have countries who are involved in war, such as Yemen and Syria, who really don't have that much access to newer drugs. So I probably have to say that the access to medications is quite variable due to the diverse populations covered within the MENA region. I think this poses a challenge, and I think we're going to talk about this later, Clifford, in terms of challenges and adaptation of guidelines.
Yes, thank you very much, Dr. Alshammari. And of course, we're asking him, as he mentioned, MENA, of course, Middle Eastern and North African. So we're asking him to have quite a bit of breadth in his description. Thank you very much. So let's move to Latin America, Dr. Trindade.
I think NCCN has been the guideline most used by doctors in Brazil for many years. We have our society's guidelines, but they have a smaller reach, serving more to support the approval of cancer treatments requested to the health insurance companies than to truly guide the doctor's actions. So in terms of helping to choose the treatment, the NCCN guidelines has much wider acceptance and capillarity among clinical oncologists in Brazil than any other guideline. So that's why we are trying to adapt this guideline to the Brazilian doctors so they can really have these possibilities of treatments of NCCN in our reality of Brazil. This is not the same for all patients.
Dr. Trindade, but even before we get into the NCCN guidelines themselves, I wonder if we could just back up a bit. Can you help characterize at a very high level cancer care in Brazil, if not more broadly?
Sure, because we have different conditions for cancer treatment because Brazil is a continental country. In general, we have 85% of the population in Brazil in the public health system, which provides free care, but very limited treatments. For example, we don't have immunotherapy for any kind of cancer in the public system. But in the other hand, 15% of the population pays for the private system with a wide access to most approved treatments. So it's for this 15% of the patients, but talking about Brazil is a large number of patients. We are trying to adapt to the guideline.
Good, thank you very much. Dr. Tsikai, I wonder if you would do the same, and as you're giving your overview of cancer care there, maybe you might want to say something about, I know cervical cancer and data and so forth might be a particular angle you might want to address, but Tell us about, at a high level, the cancer care issue in your country.
Thank you so much. Yeah, so cancer in Zimbabwe is on the increase. It has really become a major, major issue for us. And a lot of our patients, unfortunately, are presenting with very advanced disease due to quite a number of factors, mostly lack of awareness. We have patients in the rural areas. Some of them, have not heard about cervical cancer, breast cancer, cancer in general. So we do try to do a lot of awareness campaigns, but there's still a lot of work that needs to be done. And what doesn't help the situation is that there are a lot of myths that surround cancer. A lot of people think that they've been bewitched. So when we do tell them that they've cancer, they'll go to the traditional healers. They will use herbs as treatment. There's minimal trust in conventional Western medicine. So we need to educate a lot of our patients and just the general public as a whole. And then you also find that the cancer that is most common, like you mentioned, number one cancer is cervical cancer, which in other countries has actually really gone down in incidence due to widespread screening, population-based screening. But because of lack of resources, we're not able to actually do population-wide screening. So we are finding cervical cancer as our number one cancer. And being number one cancer like that, also in quite advanced stages. So the other challenge that we're actually facing in Zimbabwe is that a lot of patients have to pay from out of pocket. So they have to pay cash for treatment. So as much as we can go and we do free screening and we diagnose cervical cancer or breast cancer or prostate cancer, which is the most common cancer in males, you would find that it really becomes unethical if we're not able to actually offer treatment. So it is a challenge. NCCN guidelines have really come in to assist us, to advocate to our government, to actually fund for the medication, evidence-based medication. But we have a long way to go.
Thank you, Dr. Tsikai. Just one more question along these lines. I understand in Zimbabwe that there are some very wealthy people and some many, very poor people. Could you characterize the sort of economic diversity across the country, and does that have any bearing on cancer care access?
Yes, you are so right. There are really major disparities. You would find patients that have medical insurance, that's less than 10% of the population. They're able to access sort of state-of-the-art care. So you find that the NCCN guidelines, that standard of care, we are able to also offer it in Zimbabwe to those patients, but that's really less than 10% of the population. The rest of the population would require state funding. They would require their relatives in the diaspora to help them pay for treatments. But it really, really is a challenge. That's what we're really facing when we're talking about chemotherapy access. We're talking about radiotherapy for cancer treatments. We do not have enough equipment. We are short of medication. But like you're rightfully saying, we do have a group of patients that can afford, expensive medication. And what we also find with the group of patients that can afford, a lot of them will go out of the country to access care overseas. So also that becomes a challenge in terms of actually improving the care within our country, because people believe that they can get better care outside.
So those are points that are very, very well taken. I'm glad you're characterizing that way. You really deal with a very broad range of economics and capacity, but the prevalences that you cite for cervical and prostate are still quite high. So thank you very much. Let us travel over to Europe. And Dr. Rutkowski, at a very high level, can you sort of give us a description of the system capacity there?
So in Poland, like in several European countries, this is obligatory healthcare insurance based on the public insurance system. So we have one obligatory insurance system, which is state insurance. Of course, some people can get some private insurance, but generally it is obligatory to have the equal access. For drug cancer drugs, the access improved during last 7-8 years much, because now we have in major cancers the access to all category 1 NCCN drugs, what is very important. However, we have such so-called drug programs, so patients can be treated according in designated centers. This is first. And second, according to the specific rules. So, for example, some drugs can be used only the first line, not in the second line. So, but generally, this is well established now. The Achilles heel is probably prevention, because although we have full access to all prevention examinations by screening for cervical cancer and breast and colorectal cancer is really on lower level than in average in European Union countries. So also the mortality due to cancer is unfortunately higher. However, it improved during last years, especially for melanoma, for breast cancer and lung cancer, what is partly related to the better awareness, like in melanoma, but also full access to the new active drugs. So this is the current situation.
Thank you very much, Piotr. Very helpful. Let's go to Vietnam now. And Dr. Huong, can you please tell us the main characteristics of the situation there?
Yeah, thank you. And Vietnam is a country with nearly 100 million population. And cancer is the most second cause of death in Vietnam, and it's increasing. And the most common therapeutic risk of the cancer is smoking and infectious disease. And smoking, the rate of smoking in men is around 41%, is very high. But in women is only 0.6%. And the rate of the passive smoking is around 37%. And breast cancer is the most common cancer in women. But the lung cancer is one of the most common cancer in men. But unfortunately, more than 70% of the patients diagnosed at late stage. And we have the National Cancer Programs approved in the 2008. But the lung cancer is no priority for the screening in the National Cancer Program. And we also have for the cancer surveillance to prepare for the national plan. We only have 9 cancer registry, but only 2 as a population-based cancer registry, and it's cover around 25% of the population. And there is a lacking of the cancer surveillance in the country, because the cancer registry only collects the core indicator. We are lacking of the mortality, the survival and the mortality in the cancer surveillance. And we also, the Minister of Health also issues a guideline for the cancer treatment, but normally it's updates very late. And that is why in 2023, we collaborate with the NCCN for the harmonization of the 10 most common cancer in Vietnam. And because the lung cancer is a big issue and priority, so lung cancer is the first kind of the cancer that we do the harmonization.
Thank you very much. I'm very glad you brought up the issue of lung cancer as a leading type of cancer. Can you say a little bit more about patient awareness with regard to lung cancer in Vietnam?
Thank you. That's we do the many type of the awareness program. Before we start the National Cancer Control Program, we also do the national study to identify the knowledge of the people in the community on the cancer control and cancer prevention. But the knowledge is of the people in the community is very low. But nowadays, it's around 50 to 75% of the people at that time thinking that the cancer is cannot treat it. But nowadays, after we are running 10 years a national program, the knowledge of the people in the community about the cancer prevention in general is improving. But the knowledge on the early side of the cancer is still very low, and that is why in this time we do the different awareness program to improving the knowledge of the people concerning to the early side of the common cancer in Vietnam.
Good, that's very helpful. And I'm glad as well that you talked about the data issue with surveillance data and so forth. So thank you very much. I want to move now to back to the NCCN guidelines as we now stand. And I'll go back to Karine Trindade on this. You started to say this. Where are we now with regard to the use of NCCN guidelines in the region and for, over the last 5 years or so? Where do we stand?
Sure. As I was talking in this question, NCCN has been the guideline most used by all doctors in Brazil for many years. And we have our society's guideline, the Brazilian Society for Medical Oncology guidelines, and I participate in these guidelines, but it have a smaller reach. It's used just to when the healthcare companies request the justification for some treatment, we use this guideline, but not to decide our treatments. In terms of helping to choose treatment, NCCN guideline has a much wider acceptance with clinical oncologists in Brazil than any other guideline, even our society's guideline. And
really? Let me just stop you for a moment. Why would it be that guidelines that are generated largely in another country would be adapted more than within country? Because obviously there's great oncology expertise in Brazil, of course. Why? Can you briefly address that?
Yes, because I think that the society's guideline, it tries to help the healthcare insurance, so our guideline is not so large, the criteria of inclusion treatments than the NCCN guideline. I think NCCN guideline is more complete, and it permits a lot of possibilities of treatments, In our guideline, it's a smaller guideline, it's more direct. So I think this is the reason. And NCCN guideline is used not by only the clinical oncologists, but by other doctors, like the surgeons, like the radiotherapists. So I think that's another reason. And we see the young doctors and the older doctors using NCCN guidelines to help to choose the treatment.
That's very helpful. That's very insightful insofar as adaptation and adoption of guidelines. Thank you. Let's skip back to Dr. Rutkowski in Poland and maybe a different sort of picture about the role of NCCN guidelines there. Piotr?
So, similarly, the NCCN guidelines are probably Poland belongs to the countries with the highest numbers of downloads of these guidelines. And for years, it has some educational activities, practice activities, learning, and it's also used by our Polish HTA for assessment of new drugs. In our opinion, of course, we use the drug category by NCCN. But what is more important now, that we try to formalize more the impact of the guidelines, because in our national oncology strategy to decrease the inequalities, we assumed that it's necessary to develop and update the guidelines for all diagnostic and therapeutic procedures in oncology. And according to law, it was also recently allowed that we can also perform the adaptation, because for years we did it by ourselves, but for some kind of guidelines, it was very difficult. So although we have in our National Research Institute of Oncology dedicated team to coordinate activities related to adaptation, and it works, it took some time, but we have chosen NCCN guidelines for several reasons, of course. First, that they are frequently updated, they are independent, they are good quality, they are very comprehensive, and adaptation is it is not so easy also, because we have first dedicated team for coordination, but also dedicated team of experts for every type of guidelines, and this is huge work between the experts from NCCN side and Poland sides. However, for last 3 years, we have adapted several guidelines. We started from cervical cancer, central nervous system, thereafter breast cancer, head and neck, colon cancer, and ovarian cancer. So this is done. Based on that, we are preparing for the very short key guidelines version based only on that what is in Poland is reimbursed, and this is used for let's say quality indicators purposes. However, full adaptation is available on the web page in Poland, and it's used by the physicians. For this years, we started another ones like anal carcinoma, gastric, rectal cancer, hepatocellular, vulvar cancer. But what is also important, we now go further for next years for the specific population like adolescent and young adult oncology, and also for palliative care. And next step probably for next year will be also guidelines for patients, which are so generally we haven't used all guidelines from NCCN, because for some we had a very established groups which were worked according to the specific HTA rules for years. Like for lung cancer, we have own guidelines like melanoma. However, in major cancers, we started this adaptation process, and now it's very successful because we have 9 guidelines adopted, and others will be adopted soon. So this is very practical now, because we want to Polish adaptation version, we want to adapt once a year. And as I mentioned, we have also the preparation of the key facts, which is prepared based only on this what is reimbursed in Poland.
That's very helpful, Piotr, and interesting that you emphasized the comprehensiveness of the NCCN guidelines. They just got a lot of committees and a lot of people working on them in many cancers. Also that they help diminish inequalities and the fact that they're updated frequently. But it also sounds as though in Polish oncology that these sorts of practices are being adopted internally as well, which should help the whole cause too. So that's very helpful. Thank you very much. Dr. Alshammari, could you speak on behalf of perhaps Saudi Arabia, but even more broadly for MENA as well, perhaps on NCCN guideline role?
Of course. Dr. Goodman, we know that the NCCN guidelines are probably the most updated guidelines in the world. They have very frequent updates. Probably non-small cell lung cancer gets updated, I'm sure, more than 4 or 5 times a year. And the NCCN guidelines does capture that, unlike other societies, which are probably slightly slower in terms of their updates. MENA NCCN, or NCCN in general, is very followed and widely followed in Saudi Arabia, and to a lesser extent in the MENA region. Our coordination center in Saudi does conduct a large educational meeting that occurs once every 2 years. And the goal of this is to actually get key leaders and healthcare providers from the MENA region to be physically present in a space, and they get to discuss, updates in NCCN guidelines and how to face and how to lessen the challenges of access to care and other challenges within the MENA region. I also have to say that we all know that MENA region is quite vast. There are definitely differences in terms of access to care. And I think guidelines such as the NCCN does give a wide variety of options to patients and healthcare providers, and I think this is quite helpful. So once we actually do the adaptations, it is important to capture this large sort of, or many options that can be provided to patients.
Very helpful. So the range of clinical options then makes a guideline more readily adaptable to such a large region with its own types of diversity and inequalities, of course. So
absolutely.
That's a very helpful point. Let's go back to Vietnam now. Dr. Huong, if you could tell us a little bit more, you started a little bit more about the extent to which NCCN guidelines have become ingrained or adopted in Vietnam to date thus far.
And as I mentioned before, that we have the guideline approved from the Ministry of Health. And it's also very important because like Poland, it relates to the reimbursement. But the update of the guideline is very slowly. And we have one study as this study to implement in all the 91 oncology facility in Vietnam. And we realized that besides the guideline from the Ministry of Health, more than nearly 80% of our doctors follow the NCCN guideline. Yeah, and that is why, and I think that is a very valuable resource for the healthcare provider and for the doctor in Vietnam. And that is why we are thinking that to collaborate with the NCCN to develop for the guideline in Vietnam. And there are two kinds of the follow the NCCN guideline is adaptation and the harmonization. But when we read and we discuss with the NCCN expert, and we realize that for harmonization, our doctor can learn a lot. And after the harmonization, and we come to the second step is the adaptation. And that is why now we do the first step is the harmonization for the 10 most common cancer in Vietnam. And now we already done for the lung cancer, and for this year the liver cancer, breast cancer, and for some other common cancer in Vietnam.
Well, thank you for the point you're making about harmonization and setting priorities for the most important to harmonize. I just want to make sure I heard you correctly. Did you say 80% of the physicians use NCCN?
80% of the doctor follow the NCCN guideline from our study. And that is why we select the NCCN guideline. And we are also thinking about the plan, because we have the parallel guideline approved from the Ministry of Health and also the NCCN's harmonization. And now is the step to from the big National Cancer Hospital and also the National Oncology Association. We are collaboration and to send the letter to Ministry of Health for them to update, and they can accept our NCCN the harmonization guideline to become the official guideline in Vietnam.
I see. So it's clear that the Ministry of Health has an essential role, and it sounds as though they are, as we say, on board. They like the idea of working with the NCCN guidelines. And it sounds like you've thought out very clearly sort of a stepwise adaptation over time. So that's very helpful. Thank you. Dr. Tsikai, let's move back to Zimbabwe. And I'm just curious about how your take on NCCN guideline adoption, and in particular, I wonder if you could highlight areas where adaptation is particularly difficult. Dr. Tsikai.
Thank you. Yes, thank you so much. Yeah, so we've been working on adopting the NCCN guidelines for sub-Saharan Africa. And what we were basically doing was taking the standard of care, your category 1 treatments, and graying out, well, firstly, doing like an audit of the resources that we have within our countries. So looking at the infrastructure that we have, the human resources that we have, and even just our patient population. So we actually found that due to limited resources, that's, looking at diagnostics, we had to do a process of graying out a lot of what would be standard of care within the guidelines. So from what we call the parent guidelines, we would have then our own sub-Saharan guidelines. So over the years, what we've been quite excited about is as we are doing we do twice a year review of the guidelines, a lot of the stuff that we grade out in terms of the diagnostics, lack of or limited CT scanners, MRI scanners, we actually now going back and graying those areas. And that has been quite exciting to see how the NCCN guidelines have actually helped us to advocate for care within our countries, because we were able to go back and highlight all those grayed areas and say, you know what, this is standard of care, and we needed these resources. So for a lot of the countries, we have seen a big improvement, and the most exciting being PET scanners that are now available in countries like Kenya, which were not there before. So all quite exciting. A lot of targeted therapy drugs, a lot of immunotherapy, we still grade out, but quite a bit of targeted therapy. Things like Herceptin are now available in most countries. So there has been quite a big shift. So our main focus now is to try and say, how do we then shift from mainly palliative care to more curative radical care? And that's really trying to change the patient profile that we're seeing. Like I mentioned earlier, about 80% of our patients are coming with advanced stage 3, stage 4 disease. So you find a lot of the treatment that we're offering is really palliative care. And you see a lot of these guidelines are focusing more on curative treatments. So we need to shift towards diagnosing our patients at earlier stages. So that is our focus, more of advocacy, campaigns, public awareness to get the screening going.
That is very helpful because on one hand, if a country or a region does not have all the capacity, the PET scanners and so forth, you have to gray out parts of the NCCN guideline. But the NCCN guideline itself, because you show these grayed out areas, that points to areas where capacity needs to be improved, right? So yes. I think you said you de-gray it out, you reverse the process, and it's used as a way, not just how to do care, but as a way to prioritize building resources and capacity, and it could be persuasive along those lines. And then furthermore, you highlighted that traditionally, so many cancers have been diagnosed so late that you're dealing so much with late-stage cancer diagnosis and treatment, but with the system's improvement and greater awareness, maybe you could move this to earlier diagnosis, earlier stages, and maybe even prevention. So you've described in such an interesting way, Dr. Tsikai, a dynamic situation, and it sounds as though the NCCN guidelines have a useful role in that. So that's very helpful. Oh, this is great. Thank you. I want to move to the notion of guideline adherence and guideline concordant care. And Dr. Alshammari, can I put this on you to start? When we talk about guideline adherence or guideline concordance in practice, first of all, what is guideline concordant care? And does this promote patient access and so forth in real time, in practice, not theoretically?
Thank you, Clifford. So we very frequently in our coordinating center communicate with NCCN and ask them about the number of downloads. And we actually measure this during our twice or once every couple of years meeting. We actually try to see an upwards trends in terms of how many downloads occur and how many downloads occur on the adapted MENA NCCN guidelines. So not the parent guideline, but the adapted guideline. And I think this is probably one way to measure adherence to those guidelines, as we see a upwards increase in terms of the number of downloads. So that's one way to measure it. And I think, of course, it is challenging to measure it in real life. One of the things that we are currently doing in my hospital, so I do work in a large tertiary care hospital in Riyadh, Saudi Arabia, where my hospital cares for about a population of 5 million. We have a very large hepatocellular carcinoma service. And during our tumor board for the last 3 years, we have actually added a small sort of check, a yes or no, which is the tumor board recommendation. Is this in concordance with NCCN guidelines? Yes, no. And if no, you have to actually add a small part of why not. And I think this is also a way to actually measure guideline adherence and concordant or guideline concordant care. And I think it's a quality improvement project on why do we not follow the guidelines in certain cases. So that's, I think this sums it up, Clifford.
That's very helpful. So you try to quantify it by downloads of the adapted guideline. But interestingly, you also ask to provide some rationale for when there is not concordance, which may help you sort of adapt the system, correct?
Correct.
Great point. Thank you very much. Let's go back to Poland. Piotr Rutkowski, tell us a little bit about how you view guideline concordance and what makes it work.
Yes, of course. During the adaptation process, we are looking first what are differences between the systems and also the approval of some therapies, because between US and EMA exists some such approval. And second was this reimbursed. So we always, during the adaptation, if it's not approved, we have to remove this. But of course, it's clearly marked. If it's not reimbursed, it is left, but it is written that it's not reimbursed. So this is a clear information also for the future improvement, what can be changed. What is interesting, some adaptation process led to some changes in NCCN guidelines, because during the discussion with experts, one or two things were also adapted to NCCN guidelines in the future. So it's nice that European approach can be also, let's say, working in both sides. And also based on this, what was not reimbursed before the guidelines, now we have some improvement, for example, for the reimbursement diagnostic procedures in PET-CT based on NCCN guidelines. So this is a very important step also, that we do not only adapt, but we can also have some influence what should be reimbursed based on NCCN guidelines. Looking at the healthcare system, of course, it's much more difficult. Now, our institute is also National Monitoring Center for newly established National Cancer Network. And based on this short key guidelines, we are preparing together with National Oncological Council the key indicators, quality indicators based on the guidelines, which now will be measured in the system. So I think if we will meet next year, I will have some more data about how in practice we can measure the implementation of the guidelines.
Thank you very much. And I like, again, the dynamic nature of your description insofar as actually it sounds as though you have fed back to NCCN some ideas about how to adapt the guideline at the NCCN side. So it's kind of there's a feedback loop, I guess, and then how the guidelines have been used to support the case for reimbursement, which is also very helpful. So again, it's not simply you're reading something out of a book, you're doing something with it that has some feedback as well and some policy implications. Thank you. Thank you, Piotr. Karine, can you talk a little bit more about how in Brazil you view a guideline adherence in practice, how well that is working, and do you try to quantify it perhaps?
Actually, we didn't quantify yet because we just finished the adaptation a few days ago. We are trying to work in the challenges of this, the use of the guideline, because we already use it a lot, the NCCN guideline, but not the adapted guideline, which is a new thing for us. I think we just have this 15 days, something about this.
Oh, wow. How do you anticipate, so in the future, how would you like to assess or monitor guideline adherence or concordance? What do you perhaps have in mind?
We are trying to put the guideline in the LACOG website. It's another way of patients can go to the guideline, not just in NCCN website, but in our LACOG website, because we know many doctors try to go to our website in this institution that I work in to see other things like the trials in progress, this kind of things. And we are trying to disseminate the guideline in some groups of medical doctors and urologists, as it's just the prostate guideline, our first adapted guideline. And we are working with NCCN to try to understand if the doctors will go more to the traditional NCCN guideline, the adapted guideline, or the Portuguese guideline, because we also have the prostate cancer guideline in Portuguese, but it's not a new version. It's like an old version, 2021, I think the year. And we know that some doctors prefer to use the Portuguese guideline, depending on the region of the country. The majority of the doctors understand English without any problem, but we know that some doctors prefer the Portuguese one. So we are trying to understand in this next months which will be the preference of the doctors. So depending on this, we'll go to the other cancer guidelines. After prostate cancer, we are thinking about work in bladder cancer and kidney cancer, and after in penile cancer, as we are working urologic cancers for now. But it will depend of the acceptance of the doctors.
This is so interesting. In your case, you're almost working with three guidelines. One is the NCCN original, one's NCCN adapted over time, and one is Portuguese. And that familiarity with a language, English and or Portuguese, might also affect clinicians' willingness or preference for a guideline. So that's a very interesting situation, I must say. Thank you for that. I want to go once again back to Vietnam and Dr. Huong and ask you in particular about guideline concordance or adherence. What have you seen are the challenges to taking NCCN guidelines, even when they're adapted, and gaining adherence or concordance? What are the challenges to that, and what do you have in mind about to have solutions to those challenges?
Yes, and our center is the healthcare system in Vietnam is a three level of the healthcare system: the central level, provincial level, and the primary healthcare level. And our hospital is the biggest national cancer center in Vietnam. We are not only have a mission for the diagnosis and treatment of the cancer, but we also have another very important mission, is the training for the oncologists in the country. And we also have the several oncology department of the medical university located in our National Cancer Hospital. And so when we do the guidelines, the NCCN guideline, we also see that the issue is the difference in knowledge between the doctor at the provincial level and the central level. So that we also apply the knowledge and the information from NCCN guideline in the seminar and in the training and in the updates the curriculum to training for the oncologists in Vietnam. But we also why we apply the NCCN guideline, and because we also realize some of the challenge. In the previously, I also mentioned about the reimbursement after follow from the guideline from the approved from the Ministry of Health, and the NCCN guidelines updates regularly. And for some kind of the new medicine treatment is still the cost is it's a highly cost. So that it cannot cover by the health insurance. Is the more challenge. The second challenge is the English, because the doctor is the center level, so they have they can speak and understand the English, but the doctor at the provincial level, maybe the language is a barrier for them to follow. And I think that is the two most challenge for Vietnam. And the solution is that is why we have to do the harmonization and translation of the NCCN guideline, and we try to put on the website of the Ministry of Health, of the Vietnam National Oncology Association, and then the many doctors in the country, they can read and they can follow the NCCN guideline.
Well, thank you for describing those challenges and your thoughts on them, financial and translation, and how you harmonize. I wonder maybe someday we can use AI, artificial intelligence, and large language models to efficiently translate from one language to another easy, but maybe not today, but maybe soon.
Hopefully, yeah, soon.
We hope so, maybe. That would be a good application of AI. So Dr. Tsikai, once again, coming back to you in Zimbabwe and maybe more broadly Sub-Saharan Africa, with regard to guideline concordance, can you say a little bit more about the challenges for that you see, and maybe are there some solutions? Dr. Tsikai.
Thank you so much. Yeah, so in terms of the guideline concordance, we do find that the adopted and adapted guidelines have been quite useful for us in our setting. So one of the things that I actually found very useful was, just coming together with other oncologists from Sub-Saharan Africa, where you'd find that we have diseases that are in common. So cervical cancer is the #1 cancer in most of the Sub-Saharan African countries. So what we found useful was actually coming up with strategies to improve care. And one of the major things was actually learning from the other countries. So just sharing the different practices. So you'd find that where we find, because of our limited resources, we were then able to say, okay, if we're not able to offer targeted therapy, immunotherapy, what else can we do? So you'd find somebody from Zambia would say, this is what I give to my patients. So we found that we added in blue, we added to the parent guidelines in blue, all the suggestions and strategies that we found were relevant within our own context in terms of affordability and availability. So this has been actually very useful. Instead of what we would find previously was you would run out of options. You're following the parent guidelines and you get to a point where you've gone through first, second, third line of treatment and you run out of options. But with those additions in blue from the other African countries, you're able to actually open up options, be it a basic drug like oral cyclophosphamide for metastatic prostate cancer. So because of that relevance to our environment, you'd actually find that a lot of us find these guidelines quite useful, which has improved the concordance to care in terms of concordance to the sub-Saharan guidelines. But in general, when we're talking about concordance to the guidelines, we do have an issue there, because if we don't have enough resources to diagnose our cancers, to stage them accordingly with the proper imaging, to treat them accordingly, then it means we're going off protocol in a lot of cases. So then we have an issue there. So when it comes to resources, we do have issues. We also need to train a lot more of our people, the healthcare professionals, to be able to appreciate and understand, here we're not just looking at the oncologists who are really well trained, but all the other healthcare cadres that are involved in the care of the oncology patients. So that also helps with the concordance care. So we do have quite a lot of work to do. We are working on our own national guidelines, but at the same time, we found the NCCN guidelines have really helped us, come up with our own basic national guidelines. And then in terms of just even the patient, we found that the NCCN guidelines, I do share them with my patients, the patient guidelines. So you'd find, once a patient has gone through the patient guidelines, they're able to come back to you and say, but doc, why have you written for me this treatment? Because they've gone through the patient guidelines. So I've actually also found that the patient guidelines are very useful, and I strongly recommend them to our patients. Yeah.
So thank you for making that point. So if you can provide credible information to patients in a way in which they can understand it, the patient comes back to try to tell the doctor and insist on better care and more personalized care. That's something that many of us have not done very well. And I'm glad to hear you're not only looking at the NCCN guidelines from the clinician standpoint, but the patient adaptations of those. So very good insight. Thank you for that. I want to ask Dr. Alshammari and Dr. Rutkowski as well next. You both live in areas where their resource level is higher and so forth. Tell us a little bit about where you see the main challenges or barriers to guideline concordance, and just a bit about what you might do about them. Dr. Alshammari first.
Sure, thank you, Clifford. So if I'm talking about specifically Saudi Arabia, we really don't have major difficulty in access to care. We have the most sort of updated therapies available. We are a publicly funded healthcare system. However, when we talk about the MENA region, as I've mentioned before, there are major differences in sort of economies and access to updated drugs. And I think this is where the NCCN guidelines, the adapted versions, come in handy, where we get experts from and healthcare leaders from different MENA countries gather and adapt these guidelines, and they have to put all the options that are available in lower or low middle income countries and keep the most updated category 1, for example, immune checkpoint inhibitor first-line therapies in different cancer or disease sites. So you have to have this, I think, broad range of options. And I think this does help access to drugs and access to care in low and middle income countries within the MENA region.
So having those options helps. So in Saudi Arabia, largely a wealthy country, there are very few barriers to access, and you can largely have the drugs and the devices and radiology and immunotherapies and so forth. But looking across MENA more broadly, there's a bigger range, but the NCCN does provide some options, and that enables some adaptation and harmonization. Yes, thank you. Dr. Rutkowski, on behalf of Poland and Central Europe, and maybe more broadly, what do you see as the biggest barriers here? And how?
First, I will not look on the NCCN guidelines as using the proper drugs only. These guidelines are so comprehensive that covers the whole diagnostic and treatment procedures. And this is very important because even if the access to the drugs is relatively okay now in Poland, but the adaptation means that, and implementation of NCCN guidelines, that we have speed up the good quality diagnostic process. And this is not so easy because if we have some heterogeneous access to the primary oncological care or diagnosis, this is the first issue. Second issue is that not all are really follow the first steps with the diagnosis, like looking at the genetic test immediately, etc. So even if we have relatively good access to the diagnostic test, except very sophisticated whole genome, etc., but it means that if we'll follow fully the guidelines, it would help with the better diagnosis from the beginning and not sending the patients from one center to another. This is why we now launch this process of the National Cancer Network because the priority is using the same standards independently on the place of residence. This is why we need these guidelines. And this is a crucial issue. However, still we are facing the problems with the mostly implementation, not the sophisticated therapy at the end stage or advanced disease, but using the good process at the beginning where the diagnostics should be faster and better, because it means that the patient has less advanced stage. And this is what we I think it is still behind of us. So this is what I want to summarize.
Thank you for that great additional point. That's very useful. I just want to ask maybe Doctors Trindade and Tsikai just this next question, because you both started to, and I want you to say just a little bit more. What has been the role of either within region or international collaboration in developing more useful guidelines, whether it's within region or even more broadly international? Dr. Trindade, when you look at collaboration, what is the role there for developing better guidelines?
I think when we work together, Brazilian doctors and NCCN panel in doing this adaptation, the local experts bring an understanding of the specific healthcare needs, resources, and constraints within Brazil. And collaborating with international experts, we can adapt the recommendations to align what is feasible and effective in our country, such as prioritizing treatments and diagnostics that are available within our country. So this collaboration results in guidelines that are practical and actionable, giving Brazil unique infrastructure and patient demographics, which is different from other countries, mainly the North America. You know that Latin America is completely different when we talk about racial situations. So I think this enables a valuable exchange of knowledge between NCCN experts and Brazilian oncologists, trying to reflect our region situations, and not just because of the epidemiologic, but also because of the resources. You know that it's not the same in our country. We have many different situations, like in the north and in the south of the country. So we can try to adapt to all the Brazilian places. You know, we have here other difference between the urban and rural centers, we have sometimes shortage of oncology specialists in some areas, mainly radiotherapists, nursing staffs. So sometimes the patients need to travel like 3, 4, 5 hours to receive care because of the size of the country. So I think when we work together, we try to minimize this difference, not just because of the areas, but because of the different healthcare systems. We know we have more than 700 healthcare plans here in Brazil to attend 15 million people. And I'm not talking about the public, which is bigger than the private, but just talking about the private system. It's completely different. And the options are very different between one and other. Some healthcare plans, they have their own guidelines, and the doctors that working with this healthcare plans, they need to follow these guidelines and to give the patients just what the treatments and diagnostic tools that are available in this healthcare plan.
Very helpful. That's quite a bit that you've got to cope with. That's extraordinary size and diversity. Collaboration is going to be essential. Dr. Tsikai, just especially looking forward, Dr. Tsikai, on collaboration. You already gave some examples of that, but as you project ahead, where do you see the best opportunities for collaboration toward better guidelines and better adaptation for them?
Thank you so much. Yes, so the importance that I actually found with regional collaboration is within the space of unique demographics of patients, our patient population in terms of most common cancers, very similar. And another challenge that we face when we are taking on international guidelines, such as the NCCN guidelines, is that a lot of these guidelines are based on research that has been done in a different patient demographic group. So we find that when we then do regional collaboration, we're able to tap into research that has been done in other countries with patients that are similar to us, the African patients. So that research collaboration can actually really help us come up with our own data, our own patient profile, toxicity profile, and improve our own standard of care for our patients. So from the research perspective, I think that really makes a difference.
I'm so glad you raised that point because of the importance of demographic differences and patient subgroups from country to country. It's interesting that you pointed out that from other countries, you might get subgroup relevant information, clinical information of utility in your own country or region. And of course, that can work in different directions. So very helpful that you raised that. Doctor, we're going to go back to Vietnam again, Huong, and I just wonder if I'm going to ask you a bit of a different question, and I'm going to ask then that you be followed by Rutkowski and Alshammari, the other doctors. Looking ahead to best practices, we've talked about guidelines and adoption and adaptation and adherence, so forth. As you're looking ahead to say what looks like best practices and guidelines in Vietnam, can you just give us an example or two of how you see that appearing sometime in the future? Same question to Dr. Alshammari and Rutkowski.
As I said, the experience in the previously, and through the discussion to harmonize the guideline in Vietnam, our doctor can learn a lot from the evidence, because before that they know and they learn the cost and for the cancer treatment, but they don't understand why we select this medicine instead of the other medicine. But after the discussion with the NCCN expert, they know the why they can choose the medicine. Just mean they from the evidence base, the medicine is very good, for the doctor to learn about the NCCN guideline. After the harmonization of the NCCN guideline, we also have the regular tumor box discussion. And in this discussion, they follow the NCCN guideline and they have the specific case in Vietnam. And I think it's sharing a lot, sharing the experience among the doctors between the central level and also provincial level, so that it's improving a lot for the capacity for the oncologists in Vietnam. And also follow the evidence base, as Tsikai mentioned. We also develop the research and have the idea for the research on the cancer, a specific cancer, and some the different characteristics of the cancer patient in Vietnam, comparison with the other country.
So this is very useful. Your first point about an evidence-based orientation, of course, is a best practice. The engagement of the tumor boards, and then cross-collaboration across the 3 levels that you mentioned are important. And as you also mentioned before, a tighter relationship between guidelines and reimbursement through your Ministry of Health is something that will improve in a long time. So thank you for that. So just briefly back to doctors, let's go Dr. Rutkowski and then Dr. Alshammari. Looking ahead to characterizing best practices in use or adaptation of guidelines, just briefly in a minute or two, what do you think, Piotr, looking ahead on best practices?
So first, that generally the implementation of the guidelines stabilize and improves the healthcare system. And this is very important, that it should be not 1 year action, but it should be continuous process. This is very important, I think, in the for the guidelines. Second, of course, is a learning of the guidelines. And maybe in the future, using also, you mentioned about AI, I think that it's important because if you look at the complication of the guidelines and clinical scenarios, it is much more complicated than it was 10 years ago. And even now the guidelines with some additional documents have some about 300 pages or something like that. So of course, what is very good in the NCCN guidelines, there are algorithms which are much better than other guidelines, and this is a major point which we are looking using this in the practice. But of course, what is also important, if we have this adaptation, and every year we try to have the updated the guidelines. So that means that we should look also what we are missing in our system, and this is why this practice is very important. And of course, we should have a very dedicated group of experts for this updated adaptation process. This is what I wanted to say. Thank you.
And enhanced expertise for ongoing adaptation and updating, of course. Thank you. Well, Dr. Alshammari, your final word on best practices and looking ahead.
I think summing it up very shortly is guideline concordant care has to be the best practice. And I think there are challenges in guideline concordant care. There are challenges in measuring guideline concordant care. I think one of the ways to measure it is what I've mentioned before, is measuring the downloads. I think big healthcare institutions have a responsibility of measuring guideline concordant care, whether they're NCCN guidelines or other guidelines. One of the things that NCCN provides, well, we know NCCN provides a large amount of information to physicians, healthcare providers, and even patients, Clifford. One of the things that we've done with NCCN is actually translate some of the patient material to Arabic language. We found this to be quite helpful. You get patients within the MENA region asking their physicians, are you following this recommendation on the NCCN Arabic guideline or a patient material? It does say that, I should be considered for drug A rather than drug B and whatnot. And I think this does improve the practices within the MENA region.
Well stated, I must say. For those of you that are listening and watching, I hope you appreciate, as I do, that we have been able to cover in a short period of time Middle East and North Africa, Latin America, Sub-Saharan Africa, Europe, and Southeast Asia with our expert panelists. If you wanted to spend 70 minutes and, as we say, ramp up quickly on international utility and adaptation of NCCN guidelines, you could not have done better than work with Doctors Alshammari, Rutkowski, Huong, Tsikai, and Trindade. So thank you all very, very much for lending your expertise. This has been very enlightening, and you set a very good example for an international webinar such as this. Thank you all very much.
Thank you very much.
It's been wonderful working with you. We will now take a 15-minute break, and at the bottom of the hour, as we say, we will reconvene and talk about health technology assessment. Thank you all very much. Wonderful experts. Wonderful. Thank you very much. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you. Well, I'd like to welcome everyone back to our next session, Module 2, the role of health technology assessment, that is HTA, and other value considerations. This is a subject that's very close to my heart, and been following the field of HTA for a long time, and I'm very interested in the relationship between health technology assessment and cancer care, including but not limited to the aspect of guidelines as we discussed earlier. This session is going to extend until 11:45 U.S. Eastern Zone time, and you can translate that accordingly, but it's 75 minutes long. And with regard to HTA and other value considerations in cancer care, I'd like to ask each of our panelists to introduce themselves by name, title, affiliation, and their connection to HTA, if you will. And let's start out with Chris Sampson.
Thanks, Cliff. Hi, everyone. My name is Chris Sampson. I'm a senior principal economist at the Office of Health Economics in London, in the UK. OHE is an independent research organisation and a company and a charity, and I'm involved in a wide range of research projects relating to value assessment and HTA specifically, from applied evaluative studies to current policy challenges in pricing and access to new therapies in cancer care.
Very good. Thank you very much. Marjorie Morrison.
Thanks so much for the opportunity to be part of the conversation today. My name is Marjorie Morrison. I'm the Director of Policy and Advocacy with Lymphoma Coalition. And Lymphoma Coalition is a worldwide network of patient organizations. My connection to HTA primarily is my work in the HTA portfolio. I lead a global special interest group with patient organizations, and I've contributed to the consultations happening in Europe, first through UNEDA, now through the European Commission. And I also support our involvement on the European Commission HTA stakeholder network.
So Marjorie, how would you characterize your national or regional global affiliation? You got some Canada in you, and you've got some North America, and how would you characterize that?
We do. So Lymphoma Coalition is based in Canada, but our scope is global. We look at regional, but a lot of our work is really quite universal across the different regions, bearing in mind the variations between the health systems and, based on our conversation today, the HTA systems. So my hope is that I can bring a little bit of the Canadian perspective, but probably more of the global perspective to the dialogue.
Got it. Thank you very much.
Thank you.
Next, Paulette DeBecca.
Hi, everyone. I think it's perfect that I'm going after Marjorie, actually, because I now live in Canada. I'm a PhD student at the University of Toronto, really particularly interested in how HTA can contribute to the work being done in Nigeria. But up until actually all of the low-middle income countries that I can support when the opportunity arises. But up until July, I worked with the Clinton Health Access Initiative, where a lot of the work I did was advising the government using research that some of which I led and others being done in other parts of the world and Sub-Saharan Africa to inform policy around access to cancer care. I'm so happy to be here as well. Thanks.
And thank you as well for bringing your international perspective. Tiet Albrecht, Dr. Albrecht.
Yes, I'm a medical doctor with a PhD in health services and health systems research. I work as a senior researcher and project manager at the National Institute of Public Health of Slovenia. I have three types of experience I can bring to this table. One is actually work on HTA within the projects that the European Union had launched in the building of the European network of HTA agencies. Our institute eventually was not chosen to be a member of that network. That's actually a governmental agency that became the member of the network. Secondly, I'm the president-elect of the European Public Health Association, and within our midst, we also have a section on HTA. So this is an important aspect, not only for the topic in question, but also broader of public health importance, access to care, and so on. And thirdly, it is a topic close to my heart because I coordinated European projects on cancer control, and various aspects of health economics related to cancer were also part of the discussion. And we, of course, worked closely with the scientific societies like the European Society of Medical Oncology and similar, in where, of course, and patient advocacy groups where, of course, these issues come up very often. Thank you for your invitation and for the opportunity to join this panel.
Thank you, Chief. Very helpful. So I know that not all of you are engaged in cancer every day, but I want to pose the question to you to give us a little context for cancer care and delivery, either in your country or your region, or maybe even global differences. I just want to set up, before we get into HTA per se, how you're characterizing the cancer care context or landscape that's most familiar to you. So Marjorie, can we start with you then? Because I know you've got certainly a cancer-specific area, but even more broadly to describe any context that's relevant here. Marjorie.
So I think getting the right treatment at the right time is really a cornerstone of good cancer care. But having said that, globally, more broadly, there's so many variations in terms of how that looks, whether it's because of health expenditure, infrastructure, barriers, challenges, and I know we'll get into a lot of those different pieces throughout our conversation. But I think, in terms of the characteristic, what we're really seeing across the regions is more of a focus on engaging patients, so patient involvement. And it's really about looking, and it's multi-sectoral. So we're working with scientific societies, we're working with clinicians, many of our members are as well. And it's really about that drive for equity, so equitable cancer care, good standards of care, application of them, models of care, including supportive care services. So we're definitely seeing that patient involvement piece and that shared priority about equitable access, equating to equitable outcomes and improved outcomes. We're also seeing more focus on data collection. So patient experiences, patient preferences, really playing more of a key role and being quite instrumental, not just in the process of HTA, but in broader cancer care. I think we're also seeing more coordination between primary care and specialized care services. Keeping in mind, within the lymphoma ecosystem, we have more than 80 subtypes. So it's really quite critical that there's that integrated care model where we're talking to everyone and where patient interests are really, I think, at the core of what that dialogue looks like. Cancer care is evolving. We've made so much progress, but we still have quite a ways to go.
Well, I'm glad you've highlighted patient involvement, patient data collection, and care coordination. Certainly that helps set the context very well, and you bring a very useful perspective, noting, by the way, that there's not just one version of that condition. Paulette Becca, you've got a public health background, and you've got experience spanning sub-Saharan Africa, particularly Nigeria, as well as Canada. So although you're not a cancer person per se, what can you say about the cancer healthcare delivery system or other aspects that may be relevant for us in our discussion at HTA in a few minutes?
Certainly. I mean, in the last 5 years of working with CHI, actually was primarily cancer focused. And that's where a lot of the HTA work around cancer care played, that I did played a role. And in Nigeria, in a lot of low middle income countries, you still have a huge chunk of patients paying out of pocket. So the critical role was, how do we make sure that when patients are paying out of pocket, they're getting value for their money, right? So that the quality of the product is standard, right? The SRA approved products that are also used in high income countries in Europe and America, and also that they have access to it at a price that allows for not just palliative care, but even if it's palliative care that they're getting the best care that they need. And so from the initial component of our work, it was really, what do the clinicians need, right? And that's where the NCCN guidelines was really valuable with the adaptations, right? Again, I'm glad that we came after the first session, because Dr. Nomsa made it very clear, sometimes what you have is, you see the guidelines and you're like, oh, wow, I can't do first, second, or third. And so what am I going to do to support this patient with, even just living, pain free throughout their process of receiving care? And so that's where the blue comes in, where, getting input from other practitioners in the region. What have you done? What do you have access to? And I like the fact that she used cyclophosphamide, because even with oral cyclophosphamide being the option, sometimes quality cyclophosphamide is a challenge. And so what do you then do to ensure that it is available, patients have access to it when they need it, even though it's not, for lack of a better term, the highest standard of care? And so that's sort of what it looks like in the region. And so working with the pharmaceutical companies and with ACS, with the American Cancer Society, to set up that market shaping mechanism where you're offering patients, prices that they can afford, that then allow for the government to start to see an opportunity to cover care. And that's really what happened in Nigeria, where with the launch of the Cancer Access Partnership, which was made available through the partnership with CHI and ACS and pharmaceutical companies, you then had the government saying, you know what, we can cover care for indigent patients who have the top 3 cancers, top 3 prevalent cancers in Nigeria. And then you start to see other things happening in other countries, because again, what you have is cross-learning, cross-partnership, right? Especially in countries that are within the same region. You see a Cameroon and Ghana saying, if you can do it, can we figure out how we can do that in our countries as well? And so that's in a nutshell what it sort of looks like, where from a place of where we didn't have these quality medicines or access to patients, what are the mechanisms that we can use? And full procurement was what we used in Nigeria, and what a lot of other countries are also exploring and implementing.
Well, thank you very much, Paulette. I'm glad you hit on out-of-pocket costs for patients, their ability to gain value for money, assessing clinicians' need and trying to meet it, accessibility, and using the procurement process as appropriate. Again, we're going to see very soon how HTA can be pivotal in some of these considerations. Tid Albrecht, tell us a little bit more about how you see the cancer care delivery system, kind of set that up for us so we can subsequently address the HTA aspect. Yes, Dr. Albrecht?
Yes, sorry, there was a break in the connection.
Okay.
Could you repeat the question? I'm sorry.
Yes. Can you help characterize aspects of cancer care delivery, whether it's Slovenia or regionally, that may help set up our subsequent discussion about HT in particular? What are the social, economic, clinical aspects that you want to highlight in particular with regard to cancer care delivery? Yeah.
Yes, I think that what we see, especially in the European Union member states, but also broader in Europe, of course, cancer is treated more or less in most countries as a protected entity, which means that it enjoys some privileges as compared to some other chronic diseases. Having said that, of course, many countries are still facing challenges in financing, especially more advanced and more complex types of treatments. A particular case, of course, is in the introduction and reimbursement of newer therapies. What is a changing landscape, I would say, especially in the last, has been over the last years, is actually the advances, especially in the medical treatment, and strengthening the perspective, that you don't have a binary outcome in cancer, as I tend to say. So it's not either death or survival, and all of that in the short run, but we have various options. We have people who are being treated for cancer as a chronic disease with chronic therapies. We have patients who will never get cured because the treatment has managed just to freeze their disease in time for a certain period of time, but they can enjoy a rather high quality of life, many of them, irrespective of the fact that they have a disseminated disease, which had never been the case in the past. So I would connect to what Marjorie already started. The patient-relevant outcomes are now even more important than in the past. In the past, it was survival, and then you should be happy that, you survived, and the quality of life was not maybe the primary target. Now, I think that the quality of life is very prominent. And that's why we need patients on board, because, of course, clinicians judge the outcomes differently. Even though, of course, that's not surprising, we need to have patients, their outcome, their perception of the outcomes, and especially the quality of life. And also, what we stressed, there's another important aspect that I would like to bring forward, and that's the patient pathway. So it's not the clinical pathway, it's the entire pathway between diagnosis and follow-up care, whatever the outcome.
Okay.
That means that we can map the needs of patients much better, arising from different trajectories. One trajectory is a palliative care pathway. One is a long-term remission. One is chronic therapy. One is, let's say, occasional relapses or something like that. Or one is the metastatic disease. And we can then map, individual needs better. And it's also easier to compare pathways across regions of the country, even compare them across countries. And I can tell you one interesting thing that we realized that this has been improving, what I'm going to say now, that follow-up care about 10 years ago did not have really clear guidelines. So it was driven by the institution, how often you are going to return for checkups and what type of tests you will have to undergo. This is also a changing panorama.
Okay.
We
can return. I want to return to that issue in just a bit. We need to move on, but we'll come back to one of those issues soon. I'm glad you talked about cancer as having been a protected entity That may not be the case much longer. We'll see. And the important aspect of looking at quality of life as opposed to merely survival. Chris Sampson, I don't know if you want to kind of talk about the NHS and cancer care in UK, or maybe you could bridge that into why health technology assessment has a bearing on cancer care and delivery. And then I'll even ask you a little bit more to describe or define HTA as we now know it. So Chris, take your pick about how you'd like to do that, but I'm asking you to make a little bit of a bridge here. Chris Sampson.
I think I can do that because actually I think there is a very intuitive link, which hopefully I'll describe. So I think our research at OHE is global nowadays, but they say that the closest thing that British people have to a religion is the NHS. And I think no matter how much time I spend doing research on other settings, the NHS is flowing through my veins. And I think that's the defining feature really for cancer care in the UK. It's centralized, it's clearly structured. There's a real emphasis on equal access to care. And actually that reassurance of equal access to care is part of the reason we have challenges in some other respects, which I'm sure we'll get to, and which some of the other panelists have already signaled. And actually, although HTA was invented in the US, I'm reluctant to admit, it fits most neatly with a situation in which there is central planning, national allocation of resources to healthcare. So I think that's maybe part of the reason that HTA has been so successful in the UK with the National Institute for Health and Care Excellence, NICE, which in many respects is seen as a leader, one of several leaders in the world in terms of HTA methodology, even if not everybody would agree with everything that NICE does. But I think it's fair to say that it's an innovator in HTA. But in terms of that kind of definition of health technology assessment and why it's important, I think HTA is one of those things that has a very clear meaning to some people. I guess all of us on this call at the moment have an idea of what we think HTA means, but it is difficult to define. And I think, well, fundamentally, it's a process that's used to determine the value of health technologies. And that process of determining the value is what enables us to allocate resources most effectively and achieve the best outcomes that we can achieve. But I find it's easiest to define HTA in terms of some characteristics that I think are consistent across HTA settings. And I think 5 of them come to mind. I think health technology assessment is formalized. It's a clear process. Somebody has written it down. It's consistently followed. There are usually rules and recommendations. So it constitutes a formalized process. I think it's systematic. HTA doesn't involve a surface level or heuristic consideration of a technology. It systematically considers everything that is believed to be within scope. I think it's a technical process. It involves experts, often lots of data and analysis. Related fourth point, it's multidisciplinary. HTA doesn't really work if you just have clinicians around the table or just economists. That would be terrible. There's a wide range of perspectives, and we've already spoken about including patient perspectives, patient voice in these kinds of discussions and this kind of decision making. And then fifth and final, maybe this is a less common term that's used in relation to HTA, but I think it's goal oriented. We'll speak about value at some point today, I'm sure, but there's usually some kind of objective associated with HTA processes, whether it be improving health, improving equity, quality of care, probably some mix of all of those. So yeah, they're the five characteristics that come to mind for HTA. And in terms of why it's important for me, it's about allocating resources as effectively as possible, but that's probably because I'm an economist. So the why it's important will probably be something that everybody could answer slightly differently.
Well, thanks very much, Chris. That was quite a job well done. You addressed its formalized, systematic, technical, multidisciplinary, and goal-oriented. You in particular look at resource allocation. And I'll just add that insofar as our discussion today, what we want to also look at is how HTA is, in some important ways, a gatekeeper. HTA can be a gatekeeper beyond the regulatory hurdles that new diagnostics and therapeutics and other interventions have in cancer care, even if there's regulatory approval as appropriate for any one of those healthcare interventions or technologies, there may be an HTA gate as well that gains reimbursement or access. And that's why HTA, more or less in many countries, has a literally pivotal role. And of course, it's got a very strong role in the UK with NICE and the National Health Service and so forth, but in other countries as well. And so that's what I'd like to ask our other panelists at this point. Marjorie, back to you insofar as your constituency, I'll call it. How do you see HTA's role influencing innovation or access to care?
So first, Chris, I think that was an excellent job. So thanks for setting it up. It's quite interesting. I was at a recent symposium and someone had said, without data, it's just an opinion. And I've heard that quote many, many times. And I think it just to sort of ground what I'm about to say, the data is so important. And we're seeing HTA bodies like NICE, like CMA, which is formerly CADTH in Canada, really look at real world evidence, which I know has divergent views, but it does have growing interest and a growing role within the HTA process. So I'd also like to comment on the sort of the patient pathway and the quality of life piece. Within the patient community, and I'm speaking quite broadly, but I'm also drawing from what I've heard, conversations I've had, events we've attended, and results from our global patient survey, which we hold every 2 years, which gives us that evidence-based data that we work with at the scientific and clinical levels. HTA offers an opportunity for patient groups to reach out to their respective patient constituents and really start to learn more about that quality of life piece. It is huge. Patients understand trade-offs, they understand the implications of innovative new treatments, but they also understand the price factor. And we all know that health systems are under significant strain and resource allocation is a key issue. But we also realize that some of those innovative technologies are game changers for patients who are navigating through their patient pathway. Some of whom have had, first, second, third line treatment. So I think I want to draw attention to the value of the patient involvement within the HTA process. What they bring forward is extremely valuable, and HTA bodies are more and more inviting that input. But I have to say, when patient groups participate, there's often infrastructure challenges. There's resource allocations that are challenging within the patient groups. Not everybody has the time, the skills, the expertise to be able to contribute. But one of the things we've heard time and time again for a number of years now is what happens to all of the data that we provide. We think about transparency. I think HTA bodies are doing incredible work at building transparency, which in turn builds trust. But I think patient groups also want to know that when they participate in the HTA process, that their input is going somewhere. It's playing a key role. And perhaps that's controversial to some, but I think that's a realistic, practical perspective of what the landscape is.
And thank you, Marjorie, for raising that. Because many HTA agencies act as gatekeepers to cancer diagnostics, therapeutics, and others, patients care a lot about how HTA does what it does. And in recent years, HTA bodies, HTA agencies have been more embracing of direct patient involvement in the process, which is certainly a positive. Not everyone's done that uniformly across the world, but that is certainly the case. And your organization is doing a good job at maintaining awareness of that. And of course, and before we go on, since you mentioned HTA bodies and agencies, we've heard about NICE in the UK. There's ICWIG in Germany and HAS in France, and the Canadian HTA functions as well. In the United States, there's something called ICER. We can go on and on. And those organizations are looking at very expensive cancer interventions, and they've got to balance safety, effectiveness, and cost, and so forth. And so this is it's a high stakes game. I'll put it that way. Paulette, you've had quite a bit of experience and transcontinental experience here. Can you help characterize HTA as you see it and how it might influence cancer care delivery? Paulette.
Certainly, thank you. And I think, just highlighting that it's a growing need, especially as low middle income countries start to really consider what universal healthcare looks like. As everyone has rightly mentioned, it will inform reimbursement. It will inform how the government decides on covering the cost. It has already done that in some countries. I gave the example where in Nigeria we have what we call the Cancer Health Fund, which is the government's first attempt at covering, cancer care for the population. And what is happening is really, we still have pockets of academics and the government, doing research and applying the methodologies that I must say, Cliff, thanks so much for sharing that really valuable document on, the processes. Because as I was going through it, I was like, oh, we're doing a little bit of this and we're doing a little bit of that, but not in a coordinated way. And I think that's where it is. We are exploring mechanisms to have it be coordinated, but it doesn't mean it's not happening, right? In Nigeria, for instance, and certainly in Cameroon and Ghana, there is a department within the Ministry of Health that's responsible for providing guidance through the essential medicines list or the essential technology lists, right? And in cancer specifically, again, as Dr. Nomsa mentioned, you have the clinicians that are part of the African Cancer Coalition working with NCCN to harmonize those guidelines to say, okay, we're going to take this gold standard and figure out how it can play out here. But I definitely say to Marjorie and to Tit's point, we're figuring that we're not going to just stick with working with the clinicians and policymakers only. We're going to start now to include patient voices. And what we also have seen is it helps with understanding some of the nuances, especially since they're still paying out of pocket, right? It helps with explaining what are those trade-offs that need to be considered as you develop a policy that covers, that guides clinicians or that supports the health insurance companies or that guides the government with providing care, right? So it's like we're starting now we're saying, based on the science from other regions, we have to start including patients. And I must say that, at least in Nigeria, they are very, very vocal in, you have to listen to us. You have to consider what it takes to access the medicine and be confident that what we've been told about the pathway is what we're going to experience, and also, quality of life as well. Yeah. So it's really very much there's still silos, but now several countries, I would say Ethiopia, Nigeria, Cameroon, South Africa, all figuring out what does coordinated HTA look like, especially as we begin to focus on covering more members of the population, covering their healthcare, costs. So what does that look like? Yeah.
Yeah. You bring up a point. You weren't explicit about it, but it comes across what you're saying. Not all HTA is done by an organization that has HTA in its title. There are
100%.
other functions in healthcare systems that have a similar gatekeeping role,
100%. Yep.
which gatekeeping role involves some combination of assessing safety, efficacy, and/or effectiveness, cost effectiveness or other economic implications, and then maybe social, ethical, legal implications as well. And now lately, environmental implications, of course. But so it doesn't always say HTA in the label. Another point that you've made, I think, and this goes along with some earlier discussion, and I just want to make sure I'm kind of grasping this from across your statements, and that is, we've talked about the role of guidelines as guidelines being very influential for clinicians and healthcare systems. But related or even independent of that health technology assessment, well, HTA may provide some input into guidelines, but most importantly, it's input into, as we heard from Vietnam, ministries of health and other decision makers that cover or don't cover and pay or don't pay for interventions. And so that's where some of these national level agencies have a lot of visibility. NICE is, of course, maybe the best example, but that pivotal role is something we've got to consider. And with that, I'm going to come back to Tit because I want you to make a connection here. You, at your outset of your earlier remarks, you said that cancer had been a protected entity, cancer care. Do you think that careful scrutiny by HTA and its emphasis on cost effectiveness when it looks at a lot of expensive interventions might change that or place cancer care under a brighter light? What do you think, Dr. Albrecht?
I think it's a very interesting question. In one of our previous projects, we also talked about disinvestment. Disinvestment as an important move to revitalize and to update care, of course, across the board. But for cancer, it's also a very relevant entity, because what happens is that there is an accumulation of incoming treatments and diagnostic and other therapeutic procedures where, some old-fashioned ones remain and they continue being practiced. I'm sure not maybe universally, but some patients are still exposed. It's important to have a sort of a dynamic. And I remember that Canadian colleagues from Toronto, health economists, were putting forward even some numbers, how much they saved, not reduced. You had a provocative point in your question. Of course, it was not reducing elements of care. It was actually saving money, because obsolete treatments that later produced no outcome or adverse effects even were eliminated. I think that scrutiny is important from the point of view that Paulette brought up. So there is the clinical perspective, but there is broader perspective. And of course, the clinician, I worked as a clinical doctor as the beginning of my career. And of course, your perspective is an individual patient. You are not maybe a group of patients at best, but you are not so interested in broader population aspects. Of course, even, people who work with advocacy groups, they have to look at the bigger picture, and they also look at the different outcomes. One other thing that I wanted to bring in forward is that a lot has been focusing on pharmaceuticals. But of course, other technologies have crept in more silently, and there hasn't been, and robotic surgery is one of those evident examples of something very costly, entering the system because it's promoted by very limited oligopolies, let's say, very few providers, no clear benefits at start. And, on the one hand, so we have an imbalance. We have a lot of focus on medicines. It's fair because there are many concerns and issues there. But of course, you have diagnostic equipment, you have equipment used for screening. There's a lot of challenges there. And of course, surgery, even procedures in surgery. So I see HTA as an important tool for many elements of care. While, when you mention in a decision maker's circle, they always have this association, this is about medicines. So we are limiting ourselves, but we should look broader. And taking a broader perspective also is necessary because, of course, people have diverse approaches to their cancers. And you cannot have only the medical perspective, you have the surgical perspective, you have the radiotherapy perspective, which is the most challenging because of the investments that are necessary. So I try to advocate for inclusion of all aspects of care. Yeah. I know that people who are closely related to HTA would say, yes, of course, but we know that decision makers usually limit themselves to medicines.
Yeah, thanks. And you're right insofar as a lot of attention goes to those very, very expensive therapies. And we're looking at things like CAR T therapy, the various immunotherapies and so forth, and some very, very expensive other interventions, biologics and so forth. And we can't ignore the expensive scans, radiotherapy, diagnostics, and very sophisticated diagnostics these days with the next genome sequencing and all that, next generation sequencing and so forth. Back to you, Chris Sampson. Chris, can you describe for us, maybe from the standpoint of a group like NICE or a similar sort of national group, how it looks at a new cancer diagnostic or therapeutic, whether it's a CAR T or a new immunotherapy or something? What are the questions that HTA asks about it, even beyond what got it regulatory approval is appropriate? And to what extent does cost enter into the issue, and how does a NICE cope with some of these high costs?
Yeah, so cost effectiveness analysis is a cornerstone of HTA within NICE and within other HTA agencies, especially national HTA agencies, but even looking to the US, kinds of methods that ICE use, quite similar. So trading off the costs associated with the intervention, whether it be therapeutic or diagnostic, looking at the trade-off between those costs and the outcomes for patients. And maybe now is the time to talk about QALYs, or maybe later.
Dive in. Go do it, Chris.
All right, I'll go for it. So
we're going to talk about methods in a moment too. Go ahead.
Cool. So quality-adjusted life years are a metric that NICE uses and that lots of other organizations use that facilitates comparisons between different clinical areas. So an HTA agency might need to make decisions that involve trading off a new treatment for a particular type of cancer versus a new treatment for Alzheimer's disease. And we need some kind of consistent basis for valuing those therapies. So cost effectiveness analyses using quality adjusted life years are a key part of that decision-making process. In recent years, to pick up on a couple of the points that were just being discussed, in recent years, the overall budget impact of the therapies being adopted in the health service is increasingly being considered more formally. So if we take NICE as an example, but there are other examples elsewhere, NICE uses what's called the budget impact test. If a new therapy is going to incur costs above £20 million to the NHS in any of the first 3 years of its rollout, then extra processes are put in place to deal with that. So we have this set of processes which has been adapted in large part in response to new cancer therapies. It's worth bearing in mind that over the last 25 years, about half of the technologies that NICE has considered have been cancer treatments. So innovations in new cancer care drive innovations in HTA methodology across the world. So I think the impact of cancer care on HTA is as important as the reverse. But yes, in a lot of settings, including in the UK, cost effectiveness analysis and consideration of the overall budget impact are key inputs to the decision-making process.
So it is essential that we all hear the last point you made, which is not that HTA manages cancer and HTA affects cancer care in one direction. In fact, cancer innovation and issues with access and costs have come back to influence how HTA is conducted by a NICE, by an ICWG, by Haas, and so forth, at NICER and so forth, and in Canada too. So the issue that Tit brought up about cancer having some kind of special status, not that it was intended that way, but the issues that have arisen because of cancer care and innovation in cancer have actually caused HTA to rethink how it does its approach and its methods. And I'm very glad you brought that up, Chris. And I just want to come back to Marjorie on this. Marjorie, do you also think, I would suggest to you, tell me if you agree, that patient engagement in HTA has been driven in large part by advocacy groups in cancer who have been very vocal and knowledgeable about getting involved in the HTA process. Is that something you've seen?
I agree. Yes, it is. And I think that's really a testament to the coordination, the mobilization, but also the vested interest in HTA processes and outcomes. We know price is a key factor. We also know that at the decision-making level, in terms of regulatory reimbursement, price matters. But when we can come forward and actively engage and even take some leadership in some aspects, we're seeing change happen. And a perfect example is what's been going on in Australia around the HTA reform or transformation. We've seen patient leaders playing leadership and co-leadership roles in that whole process of looking at their HTA system. The recommendations that they came up with that cover a very broad spectrum of issues, including culturally appropriate care. So, in terms of the Australia program, the HTA system, one of the recommendations looks at Indigenous peoples and how to engage them more in the processes. So I do agree that patient groups really have an opportunity to come forward and to engage at that level. But also, as we think about the value of our involvement, we start to look at what the value considerations are. And a patient a few months back reminded me that access doesn't equal coverage. And I think we sometimes forget that. So sometimes things resonate, and that's something that I not only remember now, but will remember in the future as we continue to see HT evolve.
Marjorie, before you go on, clarify for those of us that don't quite get it right away, how does access not equal coverage? What do you mean?
So it's one thing for a drug, an innovative treatment, to get on a formulary. So the recommendation is there. Let's say the regulatory, the reimbursement process, it gets through all those necessary steps. But there are regions in the world where just because it's available doesn't necessarily mean it gets into the hands or it gets to those who need that treatment the most. And I think we're almost conditioned to think that if access is there and the protocols and the system says it's there, then it's there in practice. And That's not always the case. And as we see more expensive therapeutic options coming up, you've mentioned CAR T therapy, and it's not always about the price because some countries are approaching that very differently. They're looking at outcomes-based payments. They're looking at staggered payments based on patient outcomes. So there's a lot of innovative ways for patient groups to really get behind and that keyword advocate for our communities, but also so that when we're having dialogues like this 3 years from now, 5 years from now, some of the issues that we've been concerned about, that we've been able to introduce some sustainable solutions that work both from cost coverage, access, and patient outcomes.
Thank you so much for raising that. And culturally appropriate care, access doesn't equal coverage. Those are very helpful points for us to help to kind of see the bigger picture. Just back to you for just a moment. Can you give us the state of affairs in Slovenia with regard to the relationships among cancer care, innovation, regulation, and clinical practice as influenced by or mediated by HTA? In other words, where does HTA fit in this sort of constellation of forces involved in getting cancer care, making it available to people? I know it's a complicated issue, but I know you can handle it.
No, yeah, of course it's a complicated issue, but I have to say, and that's why I started from that point that you have repeatedly quoted, it has enjoyed a special status, the entire complex of cancer care. And this has facilitated some of the discussions. It has not undermined principles of HTA across the board. It has just facilitated that the speed with which now certain decisions are being taken is much faster. We were not exactly champions in the past. Let's say if we looked 20 years back or 15 years back, maybe even 10 years back, we had slow processes, slow procedures, and that made a lot of people very nervous and upset. This has greatly improved. So both the speed with which the decisions are taken is much shorter, and of course the range of treatments that become available is relevant, and it has greatly improved over the past period. I think it was a joint effort. It was a joint effort between the clinical fields, the Ministry of Health, and then all the agencies that were involved, ranging from the professional scientific societies, the HTA agency, which is actually nested within the Agency for Medicines and Medicinal Products, and the health insurance, national health insurance, which has been instrumental in then, providing the financial support for the adequate financing of these new treatments, and also new screening programs, which I would also stress that we have had excellent coverage and so on, at least for the 3 standard screening programs, the colorectal, cervical cancer, and breast cancer, and now, of course, lung and prostate coming on board.
So, but is HTA sort of present as an integral part of those decisions?
It is present. I would say I have to be self-critical. I mean, not of myself, but of the country's practices. I would say that patient involvement has increased. It has not been as extensive as you would expect, but it has greatly increased. And I think that has also played a role in the improvements in access to treatment and availability of treatment. And I fully agree with what Marjorie had explained earlier, the difference between access and coverage. I think that this is sometimes also still a challenge to face.
Good. Thank you very much for that. So Paulette, especially because your experience spans two very different parts of the world insofar as economic abilities and so forth, economic capacity and resources and so forth. Can you tell us a little bit about how, whether it's Nigeria or sub-Saharan African countries, might struggle uphill to try to do HTA in a way that might be modeled by other countries? Is it just an uphill battle? Is it something that can be accomplished? And where do you think it might go next? How do we kind of do we get ramped up in HTA capacity?
I definitely think it's possible, and that's where you have different countries exploring, do we have HTA agencies that are focused on specific conditions, right? In Nigeria, for instance, there is the National Institute for Cancer Research and Treatment, and that's one of their mandates, right? To try to set up an HTA approach for cancer care in Nigeria. Ethiopia has something similar, so does South Africa. And so you have several attempts to I think perhaps not that seeing cancer as an entry point to begin to address HTA for non-communicable diseases. I mean, I think to your point, Clifford, there are mechanisms and there are systematic approaches that are gatekeepers, so to speak. In the context of communicable diseases that are especially vaccine-treated ones, especially for young children, there is a very robust HTA approach applied by the Primary Health Care Agency in a lot of the countries. However, you have to apply that kind of mechanism if you're going to cover the costs, right? I mean, if we still end up coming to cost, but and it's not just about, and it's also beginning to think about equity, right? Because we have disparities. I mean, when Marjorie said it, I was like, that makes a ton of sense, right? Because even when there is access, because you have guidelines that say you should have it, you have pharmaceutical companies that have provided these products at discounted rates or at access prices, I should say. You still have an issue where there are still patients who still cannot afford it. And that's where we were able to make that argument to the government, hey, can we start somewhere to cover patients with the most prevalent cancers? And that's where the Cancer Health Fund came in for low-income populations who have breast, cervical, and prostate cancer. And there is now a march to say, can we evaluate how that has played out, and can we make that broadly for all cancers, right? And I think it's sort of borrowing from different examples. I think in some ways it's sort of borrowing from the American example, where it's like, let's start with those who are low income. But ultimately, I think what everyone is thinking about, how do we make sure that we explore universal health coverage where it's truly universal, and we're not saying these folks can't be covered. I really like that approach. Can't be covered because there are certain trade-offs that we have not considered, right? So it's certainly happening. It's perhaps in a very very initial stages of it, where there's some areas where it's like, let's focus on cancer care. Again, like I said, there are at least 6 countries that I know that have an agency that's focusing on that. And and some of the challenge is expertise, right? And so what do we do? And then maybe that's where that collaboration with other regions where they have very clear HTA approaches comes in. It's also learning that we need a multidisciplinary approach. We need clinicians, we need economists, we need patients, we need researchers who are all going to work together to then advise stakeholders. So we also need stakeholders to be educated on HTA and the value of it, so that when those recommendations are presented, they are poised to take a look at it and make decisions that equal coverage for a larger population than it's the case right now.
Great points. Thank you. That's still the uphill battle, but you've outlined some directions to take. Back to Chris Sampson. Chris, I'm going to ask you to describe a little bit more about how HTA can embrace broader dimensions of value. So what we know at the core of HTA, we think about assessing safety, efficacy, which is how well something works under ideal conditions, effectiveness, which is how well it works under realistic conditions, real world conditions, something about economics, which might be absolute cost or budget or cost effectiveness. And that's the typical core. Can you tell us more about additional dimensions of impact or value that into which HTA has been venturing in recent years? Please expound on that, Chris.
Yeah, thank you. Yeah, I mean, it's a great topic to pick up on. The potential list of things that we might value in association with health technologies is essentially infinite. Like we can list all sorts of different aspects of value that we might associate with technologies, and as new innovative technologies come along, they're valuable in ways that we haven't previously considered. So it makes sense that we should think about these broader aspects of value. And I mentioned earlier quality adjusted life years, which are a relatively narrow way of describing somebody's health and attaching the value to that. So HTA agencies, I think decision makers in healthcare in general, are keen to be able to recognize broader aspects of value. Some of the key elements of value that have been considered in recent years around the world are productivity. So being able to return to work as a consequence of a particular technology, that brings value to patients, but it also brings value to the economy as a whole. Productive individuals are of more value to the economy. Other aspects are around benefits to people other than patients, so particularly carers. A lot of innovative treatments bring benefits to patients as well as the people caring for them, particularly some advanced therapies that are potentially curative. Essentially, it can have a huge impact on people around the individual patient. So they are just a couple of examples. And agencies have looked into incorporating these things in a variety of ways. With an agency like NICE, there is always the qualitative route. So these considerations can always be brought to discussions when stakeholders, decision makers are together to consider what the recommendation about a therapy should be. So there's always that deliberative, qualitative platform for considering these broader elements of value for which there might not be great evidence. Often it's quite difficult to capture these things accurately. So it's important that there is space for discussion and to allow that discussion to inform the decision. At the other end of the scale, you can try and make it completely quantitative. So in recent years, there's been discussion around the notion that we should value treatments for more severe conditions more highly. So you can use numbers essentially to manipulate the relative value of those treatments for people who have more severe conditions. So if a person has a more severe condition, they're likely to lose a greater amount of health over their remaining lifetime associated with that condition than in other conditions, then you can essentially upweight the value that you attribute to their health improvements. And this is a way to quantitatively influence that cost effectiveness trade-off. So I think the long and short of it is that there's scope to consider a wide range of additional value elements beyond the traditional health economic analyses that we might consider. And these can be taken into account in a very deliberative, qualitative way. They can be considered in a very quantitative way, but as is often the case, a third way is usually best, that makes some combination of looking at the data and the evidence and discussing it with stakeholders.
So that's quite helpful. And so you've named as additional value dimensions productivity, impact on caregivers, severity, disease severity. You've mentioned is another way to sort of adjust or tweak this. And you mentioned there's room for other qualitative discussions as well. I want to ask you to be a little bit more specific on the matter of equity. So you mentioned equity in light of, from an economist standpoint, equity is built into quality adjusted life years through cost effectiveness. But what about equity as a matter of, in what way will the coverage and access to a technology narrow healthcare disparities and improve equity across a broad national population? Has that become a consideration in HTA? And is it going to make Marjorie Morrison and Paulette Ibeka happy to hear what you got to say?
You are teetering on the frontier of HTA, I think, right now. So depending on which economist you speak to, they might rationalize equity into an efficiency argument, but let's not do that. The distributional impact of technologies that you just described is something that methodologists, HTA methodologists, are really trying to figure out how to incorporate. And we have some recently developed methods. There's a method called distributional cost effectiveness analysis, which does
wait. Distributional cost effectiveness analysis.
Exactly.
Got it. Okay, I want to make sure we capture that concept.
It attempts to do what you just described. Essentially, the idea that the distribution of benefits across the population is important, and we would rather fund a technology that makes the distribution more equal rather than less equal. But it's complicated. Agencies are considering it as we speak.
Marjorie, are you happy with what you just heard out of Sampson?
Yes and no. I think it's okay to get it wrong in order to get it right, but I think it's better to get it right. So a few things. I really appreciate the mention of the care partners, because I think that's really critical. And there's all the external factors. There's the risk to family, but there's those impact that HTA decision making brings to the patient population and to the population in general. Really like that point. The other thing that I think of as I'm listening to you speak is making sure we're not leaving patient populations behind. So those with rare diseases or those with just a smaller patient population in general. I think that's really key. But I definitely like that the receptiveness to moving beyond price. It's not just about the price. And I think that looking at all of those factors are part of good decision making, and patients appreciate that there's a lot of factors, and I think that's why there was mention that the patient involvement isn't as high perhaps as it could be. I do agree with you. I think we're getting there, and I think some of the challenge is just those methodologies and the infrastructure and the timing. Patient groups don't necessarily have a lot of time to participate or respond with their patient submissions. But I also think we're all kind of navigating and moving and learning together. And, when I think about where HTA is going, not just from a patient perspective, but even much broader, I've started hearing, and just a few weeks back, we had a really detailed conversation at the special interest group on HTA, is AI. What does AI mean to the future of health technology assessment? Is there a role for it? Does it represent risk? Is there bias? What does that look like? So yes, I appreciate what I've heard. And I'm also excited and very optimistic about how the conversation is going to continue to grow over the coming years. So I hope that answers your question.
It answers the question, but you're making us think about so many more things now. So we have to look at AI. I guess you could assess AI as a kind of technology, but you could maybe use AI to support HTA. I mean, there's so many ways to get at that. So Paulette, just reflecting back on what Chris Sampson had said, does that sound like an appropriately broadened field of impacts or dimensions for HTA? He seemed to broaden it somewhat.
Definitely. And I think the entire time that Chris was speaking, I kept saying, what about the equity angle? It seems to be in the quality, but was not very clear. What about the equity angle? And I was really excited that you brought that up, and there was a bit more expansion on it. And to his point, one of the things that I think is very obvious is that each group or each region or each country would have to really consider context, and because he mentioned that Chris mentioned very clearly that the value considerations are really broad, and so each region needs to really consider their context and the really critical values that need to be considered as you do HTA. But I certainly think equity is really critical in the context where there's significant disparities. Again, I applaud NCCN with how they set up the academy today to talk, to have the first group speak first about what's going on with the NCCN harmonized guidelines before we start to talk about HTA, because as you heard from some of the speakers from the earlier panel, the disparities are significant. And so if you are going to be thinking about HTA informing how cancer care is governed, if we call it that, or how stakeholders make a decision on cancer care provision, equity has to play a significant role. And I definitely think that one of the things that can happen for low middle income countries is leapfrogging, right? Figuring out how can we pick up AI as you're talking about it, even though we're just figuring things out with setting up HTA. Maybe we can leapfrog and get, I guess, capture back several years that we have not, applied these. And I think there's lots of opportunities. And again, to Marjorie's point, and to also Dr. Titt's point, that you may have to set, and I think Chris has said this to an extent, where HTA has supported how a condition like cancer may need special attention. Not that we're saying that it gets placed where it gets all the attention, but it definitely has, because there's a broader. And again, I really like the caregiver approach as well, because the reason why this subject is really important to me, because I was a caregiver, and unfortunately, a lot of these were a mystery. And by the time we started to access it, we had lost my dad. And so these things are really valuable when you look at it from multiple perspectives, and we can't ignore how equity has to be front and center across all the considerations.
Thank you for that. That's very helpful. So, and I'm glad that what Chris's response, including the distributional cost effectiveness analysis, is sort of an objective methodology trying to get at equity, as you pointed out, Paulette. So we just have a couple of minutes remaining. I'm going to ask you to kind of do a disciplined thing here, hard to do. And we're going to start with Titt on this. We're going to go We'll go Tip, Paulette, Marjorie, Chris, perhaps in that order. And here's the question for you. Given our early discussion about the state of cancer care in your region or area, and our discussion about the role of HTA as it influences that, tell us one message, one essential message that you want HTA agencies and bodies and HTA functions to absolutely know or do or improve for the betterment of cancer care outcomes for people. We talked about a lot of what HTA does, what it doesn't do. You could make up a long list, but give us one in just a sentence or two. It says, listen, HTA people, when it comes to cancer care, you got to do what? And Dr. Albrecht is going to set a very good example for giving something brief and to the point. What do you have, Ted? What do you have?
I have something that summarizes what I had proposed earlier, and that is that HTA has to cover the entire trajectory and has to cover all the elements of cancer control, I would say, not only care, which includes, of course, screening and so on. So for me, this is essential. And this then also addresses the issues that were touched upon by Paulette, caregivers, equity issues, and so on. Thank you.
Thank you for that. The trajectory, key word. It's the bigger picture, not just here or here. Great. Who did I say was next? Was it
Paulette? Yeah,
Paulette, you're up
yeah.
next.
I'm gonna, yeah, and then that was perfect because then I would say, as you're thinking of the trajectory of the entire pathway, let's coordinate. That would be what I would say, coordinated HTA approaches, because I mean, like I said, that's one thing that's missing. And there's nothing that says that we can't also explore collaboration across regions, right? So whether it be the nice working with some of these countries, like Nigeria, Cameroon, South Africa, Ethiopia, that are trying to figure this out to say, hey, look, this is one way to do it. Or Marjorie's group, just supporting some of the patient advocacy groups that are really growing in the region to say, hey, this is how we've navigated this and given power to the patients to advocate appropriately. So coordination, really.
Coordination, and you tossed in collaboration as well together.
Right. Mm-hmm.
Great points, Paulette. Thank you very much. Marjorie, what's the message to the HTA people?
So values-based healthcare are outcomes that matter most to patients. We can do better with universal health coverage. We can certainly do better at ensuring that there's equitable care that's culturally appropriate, but we have to have access to the medicines. And HTA, the decision-making process, the methodologies, absolutely essential.
Got it. HTA and the value, you didn't say value-based healthcare, values-based healthcare. I caught that particular tweak on that. Thank you very much, and a powerful message indeed. Well, Chris, you are both within and outside of HTA. You're an observer and a doer. What's your message?
Well, I would agree with Tit and Paulette and Marjorie completely on all those 3 points. My one word addition would be adapt. We need ongoing methodological development that is responsive to all of the things that my fellow panelists just mentioned. And I think some HTA agencies have a tendency to conservatism, and I think we need ongoing methodological development that recognizes new innovations and the value that they produce.
Ongoing methodological innovation and adaptation. And you described how HTA has in part done such adaptation, but it needs to be a clearer, stronger message across the field.
I think so.
Got it. Well, once again, we have spanned the globe, and HTA is really an important evolving aspect of healthcare systems. We heard about how it can be pivotal and a key gatekeeper. We've talked about how it relates to the scientific evidence, to clinicians, to patients, where it exerts leverage and so forth, in particular, again, with payers. We could not have done better than having Chris Sampson, Marjorie Morrison, Paulette Ibeka, and Tit Albrecht to lay it all out for us. You've done a wonderful job. We're grateful for this wonderful input, and you've made a nice multicultural, multinational addition to today's program. With that, I'm going to turn it back over to NCCN for some final remarks and some other news. Back to you, Tom.
Thank you, Cliff. Just to close up the session here, for those who joined late, my name is Tom Hertz. I am a specialist for business development here at NCCN. I would like to thank our moderator, Cliff Goodman, our esteemed panelists, and all of the attendees for joining us today for this productive and insightful discussion. Also, I would like to extend a special thank you to our global corporate council members for generously supporting our efforts to host these events. If you enjoyed this academy and are interested in attending our U.S. Academy, I recommend looking into our annual conference that we host. We have an academy there in Orlando in the spring. And have a wonderful day, everybody. Thank you.